What we're going to do here is do my eyes. These are my eyes. This is why I did what I did from a surgical standpoint. And so the thrust of this, the motivation. So can we have all of our patients and physicians alike and eye care providers up on stage, and I'll do a little roaming. And so our goal, once again, keeping with this intention of making this as informal as we can, is to give you an opportunity to ask questions of those who have had engagement in treatment and why they chose different refractive procedures and why they were offered. And so please come on up stage, take a chair, as whatever's most comfortable for you. They're either patients of myself, of Dr. Holzman, and Dr. Gohl as well. And so they're going to tell you in their own words. They have been already asked to answer 3 specific questions. Our first patient, unfortunately, couldn't be here as he's off similarly in the wilds of the world, traveling all over the country. I think he's in Montauk. So really rough place to be, I believe. Yeah. Really tough. So, you know, it's like being on the other part of, I guess, the country. So in his own words, let me introduce kind of a little bit about a background. 52-year-old, had previously had RK done when that was the procedure in the early 90s. And his desire, much like many of the subject here today, is going to, in an effort to reduce spectacles and contact lenses. Okay, he is a practicing eye care provider, optometrist, and his intention was to make life as simple as possible. And so the question came up, would you perform a multifocal in somebody who had an epiretinal membrane? Would you perform a multifocal or an EDOF in somebody who's had RK? And I posed that to everyone here, and we can tell you a little bit about why we did what we chose to do and let Dan, Dr. Poth, tell you why. So let's let the video roll, please.
Hello, my name is Dr. Dan Poth, and back in April, Dr. Solomon implanted light adjustable lenses in each of my eyes, and it's been an incredible experience. I'm very happy with the outcome. And I'll tell you a little bit of why I did it and what it was like. The reason I did it is because 30 some years ago, I had RK and it worked out great. I was glasses free until the past 10 years. And then I became hyperopic and the lenses were thick, heavy, and I was totally dependent on them from the time I woke up till the time I went to bed. And I couldn't wear contacts because of dry eye. So I went to Dr. Solomon and we talked about multifocal implants, but due to my slightly decreased contrast sensitivity because of the RK, we decided on the light adjustable lens. I'm also a very picky patient. I like 20/15 vision, and this would be a way to get a very accurate prescription. And it was an incredible experience. So in April, I went in, had the surgery, very simple, 20 minutes. The whole staff is incredible. The whole experience was incredible. I went back 3 weeks later, and interesting, I was about a plus 175, I think minus 150 cylinder. I went behind the slit lamp. Dr. Weigel did the UV treatment. It took 2 minutes for each eye. Just put on some gonio gel, gonio lens, and then the UV light. You don't see anything really. You don't feel anything, and a 2-minute procedure. And then the next day, I was plano in my right eye. My left eye still had some cylinder, so I went back twice and did 2 more 1-minute treatments, and I landed exactly where I wanted, which is plano in my right eye, minus 1 1/4 in my left. So I have modified monovision. And this lens has a great depth of focus, even though I did not use the new version, the plus version, which has a larger depth of focus. I did the standard lens, and I am 20/15 at vision, and I'm J1 at all distances. My computer, I have incredible depth perception. I would never, ever guess that I had modified monovision setup. It's been incredible. And like I said, I'm a pretty picky patient. I like 20/15 vision, and I have not put on glasses for the past 3 months, and really, really great outcome and a great experience by everybody at the center. And I highly recommend it, especially for patients with compromised corneas like I had. And I personally highly recommend this modified monovision. -1.25 has been really, really fantastic with this lens. Thanks.
I was just saying once again, thank you, Dan, for the kind words. And I don't know if this is necessarily the format to which we could describe the process of the adjustments. I will tell you, it's not for the faint of heart. You know, this is not. It sounds really easy and straightforward, but that's about where it stops. I mean, there's real work that goes into it, so don't kid yourself. I know both Nancy, those of you doing in the audience who are doing adjustments, it's effort, and you're really kind of drilling down into a refractive outcome. And the challenge is now you've given patient options, and they want to take every bit of the flexibility that is in there. I mean, I've had some people come in. Thank you, Dan. Again, if you want to add something to that, that'd be great. Really think that they can break down even eighths of a diopter. They want to get depth of field. I mean, it really is remarkable what you wind up creating with this. And so in every instance, it gets back to the overarching thought, which you've heard time and time again from Dr. Gold, Dr. Holzman, and Dr. Rivers. Just listen to your patients. Make sure you know what they want. Because if you offer something that, or you provide an option that really doesn't work for them, it is the classic square peg through a round hole, and it's the gift that keeps on giving if you're not careful. And so now we'll roll on into the next patient. Can we cue up the next demographic, next patient history? Here's somebody that, starting off, I was almost certain, although I guess not guaranteed, that he wasn't going to come back at me with the malpractice suit, though he could have, and that is my younger brother at the far end here. And as you can tell, we didn't pay anybody to be up here because they're going to get pretty much what I'm going to give my own brother, which is nothing. So they must love me, and so I'm grateful. But let's give a little bit of the background, and if you don't have it, I can kind of roll with it. Unlike my refractive history, he is actually a latent hyperope. Not horrible. It was about a +75, +1. And he would come in annually starting at about 45. And that's another comment. I know I saw your slide, Sonny, and it was like refractive lens exchange, 45 and above, which just 6 years ago, you're like 55 and above. And so the number is dropping because of the confidence we're having in the technology. But he would come in, and I would purposefully not see him. I would send him to Nancy. And Nancy would say, nope, we're going to hold off. Is that right? Correct. And how long did we wait? 3 years. Yeah. So what happened in that time frame? Anybody? COVID. That's true too. COVID happened. But he went from 45 to 48, right? And also the lens options improved. You know, we went through about 5 different versions of multifocal extended depth of focus. And every time I'd say, wait, we're going to get a better one. We're going to get a better one. I think we got this. And he may not remember this, but I'm going to tell you, he made a comment to me. And so much like what we're trying to do with our outreach, he actually does that all the time. I mean, every year. He's leaving here to go to Ethiopia. And so from there, he'll go somewhere else in the world to do the type of work he does. He's a pediatric anesthesiologist and works on tiny little people in the most remote places. And I don't know if you remember this, but you said to me, when I'm somewhere that I haven't been before, and if I don't have my glasses, I don't feel safe. Is that right? Would you ever think that? I mean, I'd never heard that before from a presbyopia standpoint. I'm not going to be able to read something. I never thought about that. And so when he made that comment, it kind of caught me off guard. So your experience, can you give us a little bit?
Yeah, sure. Can you guys hear me, or is this
microphone?
Better with the mic. Okay. Yeah, so I had my multifocal lens placed about 8 months ago, but my journey started about 5 years ago when I first started noticing that I needed reader glasses to see my phone, to see the monitors in front of me when I was at work, to watch the TV in front of me. And initially I would say that there was kind of excitement about wearing glasses, and and that quickly wore off as I realized how annoying it was. You know, the fogging while you're drinking your coffee or tea, or you're looking under something and they kind of fall to the side and you can't see. hurting your nose after a long day. But it wasn't, my vision wasn't so bad that I needed them full time. So I went to John, mentioned it to him, asked what my options were. He kind of pushed me, down the road. He gave me the drops. The drops did work for a time, but my presbyopia was progressing quickly. And about every 4 to 6 months, I was needing to change my prescriptions. And it was due to not being able to see in front of me, even with my glasses, when I was intubating a neonate or, doing something fine.
Can you pause? I'm sorry, those of you, because again, we're outside of ophthalmology and eye care in general. What does that mean to intubate a neonate? Just give us an idea.
So in the anesthesia world, as you get a patient off to sleep, you generally cause them to stop breathing. So very quickly, you have to secure an airway by placing a breathing tube into the airway.
And how big is that tube?
Smaller than your straw in a neonate. In an adult, it's much bigger, but in a neonate, it needs to be done very quickly. So it's a nerve-wracking experience when you're inducing a neonate. So that's where I was starting to very quickly realize, oh my God, my vision is blurry while I was trying to intubate a neonate, and being able to kind of make my way through it, but realizing that it was progressing quickly, and I couldn't keep up because I was learning the hard way that I needed a stronger prescription. So we tried the drops. The drops worked intermittently. We tried cataracts. I was terrible with
contacts.
Contact lenses. We started contact lenses. I was.
Forgive him. He's not an eye care provider. Yeah.
But and for a while, I could get away with just reading my readers and not having to take them off because I kept my distance vision. And then it had gotten so bad that there was a lot of this up and down, trying to bring things into focus from far, and then using my, and then
fast forward to the surgery. You decided. You know what it is to sedate people. You know what it is to perform refractive lens exchange cataract on others. You elected to do, of course, the refractive lens exchange without IV sedation.
That is correct, yes.
Yeah.
So, that world is not unfamiliar to me, so there was no built-in anxiety of what am I getting myself into. I've done anesthesia for those procedures. I know the OR well. I had procedures. I had a molar removed, and they said, we'll give you some sedation. I said, no, I think I'm fine. I don't need the sedation. I've had other small procedures where they say, we'll give you sedation. And I go, no, I'm fine. So I knew that I would be calm in that setting. John was able to tell me long in advance what was going to happen, so I didn't have that, anxiety built in. And we were able to do it with no sedation. And for me, it was an easy procedure, 15 minutes, 20 minutes, in and out. And
and that being said, so in that regard, just to kind of bring this full circle, I'm pointing at Bruce and Andy. At our centers in Northern Virginia and in our Maryland location, we have an office-based approach. And Sonny brought up the point of cost, and I don't think we really got into that. But if you're paying to do this through a cataract, you're paying for the anesthesia, you're paying for the facility. If you're doing it in an office-based setting, once you break that down, your costs are almost neutralized. And then there's the inconvenience based on refraction of doing one eye followed by the other eye a week later. And I'm not saying this as if you can. I mean, we still offer it to our cataract patients if that's what they want, to go the anesthesia approach with insurance. But we saved time and effort in a comfortable setting that is very much concierge, which brought that along. And again, the question is always brought up at some of these events. Well, it's office-based. You don't have an IV. Is it safe? And I'm just, again, this is a debate that we have in our house as two other family members of mine are anesthesia. And I was just point out that an anesthesiologist is saying, he's comfortable. Oral sedation worked, and it provided what would be, and you'll hear in other regards here, what is a fairly straightforward process without the extra stress. Yeah, and you're happy.
Very.
Would you say if you weren't happy and I'm standing here looking at you?
I would say, gladly, I would say. But yeah, the procedure went smoothly. I would say know your patients, because there are some patients that would not be a candidate for zero sedation procedures. And that burden is somewhat on you, because you know your patients better than we do as anesthesiologists. We're seeing them the morning of. you've been checking in with them. So some of that burden is on you. Who could do it well without the sedation? Who could do it well without anesthesia?
So he's being kind. We have this discussion frequently. I would say 100% of that burden is on us as the surgeons to know who can move forward, who cannot. And that comes up in our case presentations on who's a good candidate for an office-based setting and who shouldn't be. Because again, it goes to other scenarios. I don't want to give it away from our punchline. But I'm going to roll straight through it. Our next patient is me. But I already gave you my presentation. I'm a peripresbyopic, or what would you call emerging presbyope. Nancy?
Can you go over what lens was chosen for Matt?
Absolutely
and
not. I'm
why?
not giving. Yeah. So the question came up. Thank you. Yeah, we should do that. It does say multifocal. We went with the panoptic. And in my mind, what we've noticed over the last 10 years is that going back to the Restore and the Technis multifocal, the near was there. It was always there, but what you didn't like as a provider is the unwanted side effects, halo and glare. Thank you. Do you see halos at night?
They are improving, but yes, still.
Yes. And so you need to know your patient, and he is being told every time he comes in town, which he'll know when he doesn't get an invite back to the house, that I just don't want to hear about the halos anymore. But it is real, and you have to just simply say over the course of about a year, it does get better. And it's a lot of hand-holding, and I think that's important to kind of point out. But the distance, intermediate, and near, as you heard in Sonny's lecture, 90 plus and above, 90% of patients are going to have that independence, 20/25 or better. And what I really liked about the Panoptics is just, and Nancy, you can reiterate this, it's an incremental improvement. You're just not hearing the side effect complaint, if you will, or adverse desire. So thank you. Yeah. I am our next case presentations. These are my eyes. Why did I choose drops? And it's very simple. Because we want to preserve accommodation. As you can see, I'm reading from my notes. Is it perfect? No, towards the end of the day, it gets tough. But these drops do work, and they are reality. And it's just like the other iterations, as we were talking about, I'm not getting the headaches, I'm not getting the dimming that I used to. And so each successive iteration of this technology does help. And we are here to provide care, whether that means performing surgical intervention or steering them in a direction for a later date or something down the line. And so we don't forget that. And so I don't want to assume that just because they walk through our door, we're doing surgery. And I do speak for the surgeons in the room. I mean, I assure you, they're here because we share the same belief on what we feel is best. And I hope that we are conveying that very clearly to the audience. So thank you. There aren't any questions about the drops that we haven't already touched on, so I don't want to think that we're rushing through this, but I want to make sure we get to the section. Next slide, please. So, and Andy, you may want to speak up here. Or hold on, we have a SMILE case. So, and our SMILE patient, unfortunately, was called in, another physician. He's on call, wasn't able to make it. Can we do the video?
Hey everyone, my name is Danyal Malik. I'm a PGY4 ophthalmology resident at the University of Maryland, and I wanted to talk to you guys briefly about my SMILE procedure I had done with Dr. Goel in December 2024. Now, my wife and I, we had always been considering refractive surgery, and we kept pushing it off until my wife finally decided to pull the trigger in December. We were slightly limited, however, because as we're both residents, we had a limitation on how much days we could take off for a procedure. And we were also limited because we loved hiking, we loved playing pickleball, and we loved playing basketball. So we were a little worried about having a procedure that had a flap involved. However, in December 2024, we finally pulled that trigger and went to Dr. Goel for a SMILE procedure. Now, as the loving husband I am, I 100% volunteered my wife to go first, just to make sure everything went well and make sure she fully recovered her vision after the procedure. And after everything went excellent, 2 weeks later, I had the procedure done on myself. And it has been an incredible procedure. We were seeing almost back to 100% within 24 hours, and I was able to go back into the operating room and talk with my patients within 2 days, which I thought was absolutely incredible. One other thing that I really enjoyed about the experience is I finally knew what it felt like to have a lid speculum placed in my eye, and I always wondered as a PGY2 and as a PGY3, whether it was for an injection or for cataract surgery, what patients felt like when we were operating on them and what patients felt like when we put that speculum in. So now having this sort of authentic experience of my own, I'm able to tell my patients that I know exactly what it feels like, as well as reassure them that it's not anything super painful and that it's something that you're able to handle throughout a procedure, which I thought was an incredible experience. I'm also able to advise my patients on some of the sort of outcomes and side effects. I explain how important the tears are. I explain how in the beginning I didn't really notice any dryness symptoms, but I did feel like my eyes got a little bit blurrier about 3 to 4 hours after I put my eye drops in. So I always recommend to my patients that you don't have to wait until you feel dry eye symptoms. Try taking those drops as scheduled. And it's something that's a little bit more authentic. It's something I'm able to deliver a little bit more authentically at this point. And it was an incredible experience. I recommend it to anyone that the SMILE procedure is definitely something to consider if you're considering refractive surgery.
Well, thank you, Dr. Malik. Sonny, is there anything you want to add to that? I do love that, he did it the right way, had his wife go first. So anything that we're missing as far as that presentation, anything we need to know just from an experience standpoint?
I mean, he did have his wife go first, as you mentioned, because he wanted her to be the guinea pig. And they both did well. They both qualified for LASIK as well as SMILE, but they choose the SMILE procedure as their procedure of choice.
So one of their co-residents and now our current fellow, we did PRK on him last year. Actually, let me scratch that just so you know. Our fellow at the time did PRK on our current fellow. And it was curious to me, even though he qualified for LASIK, that he also opted for PRK. Don't worry, I'm going to get to you. We'll get to this too. Sorry. So that's the curious part of it, is that he elected for PRK, and then our fellow prior to that, Andy had done LASIK on him. And so, the idea is that they do believe in the refractive options, but the procedure really has to fit a number of things, and it goes a lot into the decision-making, without question. Yeah. And so, I'm sorry, our next patient, really, he is to blame for this entire meeting in parts, and this particular section is his doing. Ann and I, when we were talking, Dr. Ender Adams, we were reviewing how do you communicate with your patients about options. We had been at a basketball game. He just expressed to me that he may have actually had a little bit too much to drink at that event when he was telling us all that he thought about refractive surgery. This was how long ago did you have your procedure? You were 40 at the time, is that right? So that's a misnomer. And it's the hyperopic LASIK, which for those of you who may not know, that's the less common one. I would ask all three of you here and ask you as well, would you at 40 do a +2 hyperope again with LASIK? Yeah. Now? Yes. Okay. 45. Now make it easier. 50 +2.
Drop, then yes. Otherwise, most of them want to see better distance in here than to do RLE.
They don't want to do anything else, right?
If they can't do anything else for some reason.
Yeah, just want to make sure we have that, because what I will say is, irrespective of where we are now, you can't judge what was standard of care 10, 15 years ago with where we are today. But I will tell you, it's one really happy patient and doesn't shy away from expressing his experience. So, Ender, please give us kind of your thoughts on that.
This is on?
Yeah, it should be.
This is on?
We're good?
Okay. So I've known Dr. Holzman probably for 25 years or so. And when I first met him, I was very interested in working with him and sending patients over to him, finding good results. But at the time, it was more with myopic patients. And as the years went by, more and more success, developing a good relationship and having him make me look good, so to speak. So then the time back in around 2004 or so, I was talking to Andy at some dinner meeting, and I asked him about, how are things coming with hyperopia? Because I was getting pretty annoyed with wearing contacts. My eyes were dry to some degree. And I just started getting interested for myself. So probably, a year later, I think, I asked him, and I said, so how's it going with the nomograms? Do you have it down now with hyperopia? And yeah, sorry. I'm not used to holding a mic. You know that, right?
Yeah.
Yeah. Yeah, I was at Bethpage. No.
Yeah. The experience, I mean, how would you say that experience was? I mean, was it, everything you heard of, was it exactly as you thought? I'm asking you to recall things. Yeah.
Everything and then some. I went ahead and had it done. Matter of fact, the next day I actually saw patients. It was exactly what he said. Go home, go sleep for a couple hours. When you wake up, you'll see pretty well. Next day I got up and I went to the office, and some of the doctors there were on standby wondering, are you sure you're going to be okay with this? And yeah, I mean, I drove to work. I guess I wasn't supposed to, but I did. Saw patients that next day. And from there on, I was fine. Right around 48, 49, I started needing reading glasses.
So when I think the comment came up, Andy, actually you brought it up, so how has that changed, and I was going to finish that thought, how has that changed how you engage your patients? This idea of 48, oh, my LASIK wore off. How many times have you heard that? My LASIK wore off, I'm back in reading glasses. And no, we all know that's not the case. But this is a moment of truth, because when I asked you how do you engage patients, what do you tell patients now about what it is to provide refractive surgery options?
So basically, having a good experience, having access to a good surgeon is very helpful. I will tell you that when I go in the room with patients and I talk to them, they're wearing contacts or glasses. A lot of times I'll look at them and just see if they fall in a range for if they're good LASIK candidates, potentially, or PRK, right? And I'll ask them, I'll say, what do you think about LASIK as an option towards contacts or glasses? And they go, oh, well, some are very interested. They jump out of the seats, and others sort of question it. And they go, well, I heard this, and I heard that, and I heard it could do this. And I go, well, that may not be true. The best thing to do is to get a consultation done. It's free. You have nothing to lose. Get the real information. The instruments that the surgeons are using constantly evolve. I always use an example, and I try to dumb things down with my patients. I tell them it's like the shuttle getting ready to launch, okay? There's so many system checks that they have while you're doing the consult that right there and then you'll get all the what-ifs out of your head in terms of whether you're a good candidate or not a good candidate. When it comes to hyperopia or presbyopia, I do caution them depending on their age, okay? If they're old enough that, you know what, you still might need to wear a pair of reading glasses, or there is monovision as an option. And so I'll demonstrate that for them. And then whether they like it and they choose that direction, fine. If they don't, then they go, yeah, I'll just take straight distance, and I understand that.
That's right.
But either way, ultimately, it's trying to get to the patient to the professionals, okay, which is you, Andy, and other LASIK surgeons, to get the consultation, get the straight answers, find out whether you're a good candidate or not.
And if we would broaden this a little bit, the only comment, it's interesting. I mean, LASIK is the Kleenex of refractive surgery, and I think we definitely need to change our nomenclature, if you will, and just back away a little bit. It totally makes sense. LASIK is the savior here. So, of course, that's the conversation. Yeah. We've worked together on a number of patients. How many will do a multifocal contact lens trial? Do you consider that as an option? Would you raise your hands if you would try that? Because, yes. Monovision trial. How many are actually monovision candidates in the room? Do you even know if you can do monovision? I am. I can do it. So I have multiple options if I decide to go down the surgical path, which I will. I don't want to wear glasses, whatever the cost may be, I want out. And I know in our practice, we do trials all the time. We send them back to the referring doctors, let them try both multifocal and monovision. So it is really, really helpful.
Well, nowadays, now you have the option of lens implants, right?
Yep.
Taking out the lens and extracting it and putting in a lens implant that can give you distance reading.
Yeah.
Or one, there's monovision. So probably another thing I'd add on is nowadays you're into second generation, right? You go into younger patients and you ask them what do they think about LASIK. Probably the best experience I had is since I was so grateful to having it done and I was so successful as a patient is when my daughter got to 21 and a half. Interestingly, she was a minus 650. And I said, hey, before you go back to school, I said, it's winter break. I said, you have time. I said, do you want to do LASIK? And she said, sure. She saw me do it when she was 5. So, with the technology nowadays and explaining it to patients, it is truly a viable third option.
That's what I was getting at. I was waiting for him to say that. It's that viable third option. And I love that you said it that way. When we're not here to take patients who have no interest in refractive surgery and push them down a path. That's not really the point. But there are people that are interested, and if you're not asking, we're not going to know. And I think Andy Morgenstern said it. They'll go somewhere else to get what it is they're looking for. And so it's having that dialogue and knowing your patients.
Absolutely. And, going back to my daughter for a second, the other thing I would add is, here she is. At 7 years old, I put her in daily disposables. And then when she got to 21 and a half, she had LASIK. She never touched a pair of glasses during that whole time. So,
yeah, no, that's a very good point. It's nice.
That is a take-home message.
It is. It really is. I mean, just know your patient and know what you can do.
It's
absolutely
very possible.
Well, thank you. Thank you. We're going to roll right along, and we'll go from one keratofractive procedure to another. I have Dr. Karen Kim here. She's going to share with us kind of her journey for PRK. Can you first tell us, 34 minus 350, why PRK, and tell us who your surgeon is?
Okay. Hi, my name is Karen. I have 2 kids, one that's 13 months old and another one who's 4. I chose PRK because of the kids. They're jumping on my face. They're literally walking all over me, pulling my hair. Their hands are everywhere on my face. So I thought PRK might be a better choice because of the no flap. I was a minus 6. I honestly didn't have any issues wearing contact lenses. But after having a baby, I was constantly looking for glasses in the dark. There was one day I put on contact lenses, went in the shower, came out. I put another one on and was seeing blurry, and I thought, oh, I dropped it. So I put another one on. Now I have 3 lenses, completely blurry, and I thought, okay, it's time to make a difference. So, of course, I've been working with Dr. Holtzman, Dr. Gene Sweetnam that I work with. He's been referring patients to Dr. Holtzman. He's had surgery himself, so, my go-to surgeon, great. Obviously, we've always been getting great outcomes. Great management with the office. The communication is awesome, so I referred myself to him. So I knew what the PRK procedure was, a little slower in recovery than LASIK, but I honestly had no issues. I was given comfort drops that I only had to refer a handful of times. The next day I walked around, honestly, with better vision, obviously, than without glasses. My vision was getting better day by day. Right now I have no halos, honestly. Vision is great. I wake up every day seeing great. I don't have to look for my glasses in the dark. So yeah, I had a really good experience. The only one regret is that I had to suffer the 13 months with my firstborn in the dark without correction. So that's about it.
Yeah, no, so do I understand you correctly when you say that regret is that you didn't do it sooner?
Yes, I wish I'd done it sooner.
Yeah, you hear that a lot.
Yeah.
I think that's a very, very good point.
Sure.
Yeah. No, that's a wonderful a kind of summary of kind of the process. I will ask this, and again, I open this. Did they go over different options? Did they offer LASIK versus PRK versus ICL? Did that come up, or did they make the recommendation?
No, I chose my recommendation.
You chose it.
Because I knew with the boys, then I only had one. I expected one boy, but now I have 2.
And the slide might be wrong here, because this says -3, so this could be an error on my part. Sorry, everybody. You really were -6?
I was -6.
Okay.
Yes. With
so,
like 0.5 cell.
Okay, so that's very helpful. Let's take that same scenario here, almost not completely, but we're talking to Dr. Sue here. You're going to tell us what your choices were, and I think this will dovetail pretty well. An EVO, so this is an implantable lens. Again, -6 plus. All right. Were you given options? And if you could tell us, who's your surgeon?
Dr. Gohl is my surgeon.
Okay.
I was given options. I actually initially signed up for SMILE, and I got to on the day of my SMILE, I got to the operating room or got to his clinic, and he was talking to me, and I was like, well, I really want ICLs instead. And he's like, well, why don't you just get the ICLs? So then we actually canceled that procedure, and we rescheduled me for ICLs.
Okay, so what was it? I mean, you obviously could have done SMILE. What changed your mind?
I think so a background, I am an ophthalmology resident, and I know ICLs have a really good result. I really wanted the best clear vision, like with good color vision, and I wanted a really fast recovery time. And I think with the SMILEs, like knowing all the cataract calcs and not knowing how that will be in the future, I wanted something that you could just take out later when we were doing cataract surgery.
All right, so pause for that because that's a useful point. That's worth making. I would wonder, and maybe Sonny, you can answer this and speak to this, and I would say it's to Andy and to Bruce and to Dr. Weigel and to Dr. Draskovic. Giving options can be challenging because now you're saying that the patient's going to choose their surgical procedure. And I realize that it's not putting it on the patient to make the choice. I get that. It really is. That's a very good point. Pre-AI and fourth generation kind of backboned IOL calculations that are being driven by artificial intelligence, our ability to hit a refractive target with lens-based surgery, meaning when you take out a cataract, your likelihood of being within a half diopter was the best study was about 57%. I was like, that just sucks. Yeah. That's terrible. Yeah. And so my goal was my entire career, really, and I'm just going to use Andy, but I'll put Sonny in there. I just wanted to chase outcomes that were similar to what he was doing with LASIK at the time. Exactly. And as you saw, Nancy pointed out, with an LAL, we, I think, have finally hit that target. We are now able to get to those results. But you brought up a good point. And that is, do we have to then look down the line to what will happen if we're going to be taking out a lens? Or if but again, there's a risk of cataract. Did you think about that?
I did. Yes, yeah, I did.
And that didn't bother you?
Not as much.
Okay.
Just with the results that I saw, like my patients and residency having with ICLs, I thought that was the right choice for me.
Okay. Yeah, and that I assume was more than just you showing up and be like, I don't want to do SMILE anymore. Or I'm going to go ahead and do EVO. And Sonny was like, okay, we'll see you next week, right? It was a little bit more of a conversation, right?
Yeah.
Yeah. Is there anything you want to add? I mean,
I do want to add something. So when we spoke about it in the room before she had SMILE, she was told that she wasn't an ICL candidate because her ACDs were 2.9. And as you mentioned earlier, the FDA in the U.S. is 3.0, but I go down to 2.85. What's your minimum? 2.85. Okay.
2.82.
Okay.
I'm really, really I'm crazy. Sure. Yeah.
About that. And so, that's the FDA range approval, but, I feel very comfortable at 2.9. And we scrapped the surgery and we did her surgery. And then she sent in a friend who is a
neurosurgery resident.
Yeah.
At Hopkins as well. And he had ICLs done and talk about stress.
Right.
But yeah, she did great.
Yeah. And how do you engage patients now? And, again, you're going into, I should say to everybody, you're going into neuro-op/strab at the same time because you see a lot of refractive procedures in that subspecialty, right?
Yeah. So I definitely feel like
That was sarcasm, by the way, everybody. It's getting late in the day. All right, sorry, go ahead. Yeah.
No, the experience really helps me empathize with the patients when, if I have some patients who are really nervous prior to getting surgeries because they're going to be awake and we're operating on their eyes and they're really nervous, I can really empathize with them and tell them that I've been through it, I know how it feels, and calm them down that way. I do agree with the other resident. I can now empathize with how a lid speculum feels because everybody always complains about it, and now I know what it feels like. And I'm like, yes, I've been there, I've done that. It's not comfortable, but it's doable and it's bearable.
So I'm going to put you on the spot here because we've seen it. I'm looking at Dr. Martin here, where you'll find patients who have refractive, a backbone of a refractive, they're myopic, but then they're experiencing some other neurologic symptomatology. And in many regards, you're like, oh, maybe we shouldn't even consider refractive surgery because we don't know what the impact will be on their other neurologic scenarios. I don't know if it's a strabismus of sorts, if they develop some type of sensory change. Has that changed the way you look at it? I mean, is it no different than trying to putting in, looking at them from a prism standpoint, or you're going to put them in a contact lens? Do you approach them a little differently now? If it's something to that effect, would you now think, well, maybe that is a good refractive surgical patient, whereas before you may not have?
Yeah, I would say so. I think as long as their neurologic condition is stable, and they would be a good refractive candidate that way.
Last question.
Yeah.
How about baseline amblyopia, subtle amblyopia? Is that an absolute no-go for refractive surgery? So I see head shaking no for those of you in the back. Yeah, again, it's not a no. It's not a no-go. It's a conversation offering surgical solutions because they're doing it one way or another. Dr. Rivers.
Yeah, I was going to say, in the military, like someone getting their glasses knocked off and they're amblyoptic in one eye, it's better to do surgery so that you don't have to worry about their glasses getting knocked off in combat. So they're still going to be the same vision, but at least they're not impaired.
That's right. And so, so to your point, and what you're hearing here on the stage, I think similarly. I mean, these are surgical solutions to reduce what could be. Not everybody sees a -3 as nothing, or a +2 as nothing, or a +75. I think we'd all agree a -5 and 6. This is a game changer, and we've done -23 at one point. And like I said, I have a very fragile ego. I need those really desperate patients to come see me, but a -2 and a +2. You were going to say something, Sonny. Sorry, Dr. Weigel, yeah.
Talk about the difference in cataract risk with Visian versus EVO ICL.
Oh, I'm sorry, yes. I was like, Visi? Maybe these drops are affecting me negative. Okay, sorry. So the question became, and again, I would share the stage with Bruce here, and Sonny, those doing EVO lenses. The question was, going from the first generation ICL without the aquapore, going to the second generation ICL with the central hole that, one, from our standpoint, allows us to avoid having to do a peripheral iridotomy. Mark Packer, who happens to be the medical monitor for STAR, was my mentor, and he did a review, a meta-analysis on the first generation, and then did it again on EVO. And the question is, what does that hole offer you that when it wasn't there, created? And it's really normal or close to normal physiologic movement of aqueous. So even if the lens is a little shallow, if you're able to move aqueous through the lens and have it travel downstream, there has to be something related to the way that lens is probably going through some type of current, if you will, rise and fall of tide that allows fluid to move more, normally, physiologically. Anything else you kind of put to that?
Yeah, I think that it's related to the YAG PI.
The PI itself.
I remember seeing a patient who dilated widely through the ICL procedure, and when the people got it really wide, I could see where the YAG PI had actually damaged and hit the anterior capsule, and I saw some cortical changes at that spot. And I'm wondering now if that's been the etiology for our cataract formation.
I see some heads nodding here, and this is where we might actually get into some controversy here. Bruce, do you believe that?
No, I think the sizing, early on, sizing was a big problem for a lot of people.
Yeah.
And I think that the sizing has gotten or being able to size has gotten so much better.
Yeah.
So I think that plays a larger role for me.
Well, that brings us, so are we saying that we shouldn't be doing PIs for patients that have narrow angles? Maybe we should go straight to, like the EAGLE study says, Zapside, just go straight to refractive lens exchange. What do you think, Dr. Siddiqui?
No, I think that there's a good claim to be made about that. Head straight to refractive surgery, but it depends on their age. You want to preserve the patient's natural lens if they have good accommodation potential.
Yeah. And so, again, the idea is that we're giving this thought, that we are working as a group to better understand it. The truth is the lens is constantly growing like rings on a tree. And it's moving towards the ICL, even though the ICL is relatively stationary. I think again, I don't want to misquote this, but it's somewhere between like 17 and 25 microns per year that the lens is adding thickness, axial thickness. So it's moving towards your ICL. Hence, the vault should be, and there's a wide range. I mean, it is really, really wide. And in the study, it did say you could be like 150 microns, but then they're like, you can go even smaller than that, and the patients still do pretty well. But in truth, what we try to do is give us enough space. And just so that you hear this as well, when we order ICLs, it comes in sizes, actual 4 different sizes, and you want to make sure you're picking the one that stays far enough away from the lens for cataract formation, but also far enough away from the cornea endothelium that you don't destroy the endothelium. And so in every regard, the people in the room doing the surgery here are very comfortable working inside the eye. What you try to do is stay away from the endothelium, but also creating a cataract is the last thing you want to generate. So I do feel better at maybe making a slightly shallower vault than a larger vault. I will also point this out. If you really look at that FDA trial, okay, I think it was like 3%. If I said to you there's a complication rate of roughly 3%, that sounds high. But remember, it's you asked or did you see an objective cataract. If you asked every single one of those patients, I think it amounted to, I'm putting my hand up, I think it was 5 patients in the study had a bona fide cataract, something like that. Of the 5, maybe 6, the majority were either 2015 or 2020 or 2025. It was one patient that had like 20/40 vision. But if you asked all of them, would you do this again? And their answer was, yep, I still would have done it. And so even though you may be creating, quote unquote, an objective cataract, that doesn't mean that it wasn't worth their time and worth their investment to proceed. And so much like our panelists, and so I just want to give them all a round of applause. Thank you so much for your time. This is a valuable endeavor. We really do have to look at the viable third option. Glasses, contacts, refractive surgery, all right? And it's a broader category than just LASIK. We're looking at multiple surgical solutions as well as pharmacologic solutions. So thank you all. We're going to give you a little bit of a break.